Support for the Journal of Clinical Oncology podcast is provided in part by AstraZeneca, dedicated to advancing options and providing hope for people living with cancer. More information at AstraZeneca-US.com.
Hello and welcome to JCO Precision Oncology Conversations, where we bring you engaging conversations with authors of clinically relevant and highly significant JCO PO articles. I'm your host, Dr. Rafeh Naqash, podcast editor for JCO Precision Oncology and assistant professor at the OU Health Stephenson Cancer Center at the University of Oklahoma. Today, I'm excited to be joined by Dr. Michael J. Hall, professor of medicine, chairman of the Department of Clinical Genetics, and co-leader of the Cancer Prevention and Control Program at the Fox Chase Cancer Center in Philadelphia, and also the lead author of the JCO Precision Oncology article entitled Uptake of Aspirin Chemoprevention in Patients with Lynch Syndrome. At the time of this recording, our guest disclosures will be linked in the transcript. Dr. Hall, welcome to the podcast, and thank you for joining us today to explain and help the listeners understand your interesting research that was just published in JCO Precision Oncology.
Thank you so much for having me, and really thanks for the interest in our work. I think it's an important subject, and I hope people will also find it as interesting as we do.
Absolutely. I think your research touches upon a few things. One, obviously, touches upon Lynch syndrome, germline assessments of individuals. It also touches upon chemoprevention, prevention in general, and it also touches upon the knowledge and understanding of chemoprevention aspects. So to start off, I would like to ask you, for the sake of our listeners, many of whom who may not necessarily fully understand the length and breadth of Lynch syndrome, maybe perhaps some residents or trainees out there, could you tell us what Lynch syndrome is, what some of the mutations are, what the implications are, and then we can try to go and delve more into the research topic?
Sure, I'd be happy to. Lynch syndrome is probably, in the hereditary cancer genetics world, one of the most common hereditary risk syndromes we encounter. Recent estimates are that probably roughly about 1 in every 280 individuals in the population is a carrier of a pathogenic variant in one of the Lynch syndrome genes. There are roughly 4. There's sort of a 5th gene that is also involved with Lynch syndrome, but really we largely think about 4 genes in Lynch syndrome: MLH1, MSH2, MSH6, and PMS2. Over time, we've begun to learn, and I'll say that the guidelines that we develop have become more specialized for each of those genes. They are not sort of all the same in cancers they cause and the way they behave, but roughly, what is Lynch syndrome? It's a syndrome of DNA mismatch repair. So individuals who have Lynch syndrome have some degree of deficiency in their ability to repair DNA via the mismatch repair system. Depending on the pathogenic variant that is within a family, that may be related to a more severe deficiency of mismatch repair editing, or, for instance, with the PMS2 gene, we've learned over time that actually the degree of DNA repair deficiency is actually a milder phenotype. These individuals over a lifetime are at risk of a variety of different kinds of cancers, the most common being colon cancer. The risk of that is variable by gene. With MLH1 and MSH2, it's close to 50% over a lifetime. With MSH6 and PMS2, somewhat lower. There are also risks of endometrial cancer, gastric cancer, ovarian cancer, pancreas cancer, a number of other ones, but they're all related, again, to the same underlying molecular deficiency, and that's this deficiency of being able to repair mistakes made in the DNA accurately. And so mutations accumulate in the genome of cells in various tissues of the body.
Thank you for that very simplified version of a very complicated topic otherwise. So, as you mentioned, these different genes have different implications. Perhaps some have higher risks for colorectal cancer than others. What are some of the current standardized approaches for screening or following these individuals over the course of their journey until they perhaps either get detected with cancer or while they're being monitored?
Sure. It's a great question because this is very much a moving target in this disease. I'm going to give you a quick second of history that up until maybe about 6 or 7 years ago, we had uniform guidelines really that any Lynch syndrome pathogenic variant carrier should start colorectal cancer screening. Usually we were recommending between the age of 20 and 25, and this was usually annual colonoscopy. And for years, that was the standard. In more recent years, we've stuck to that tight interval, particularly in the higher risk genes, MLH1 and MSH2, although the guideline now reads every 1 to 2 years because we recognize people need some degree of flexibility to live their lives. And there are people in the population who are more risk averse, and there are those who want a colonoscopy every year because they want to stick to that schedule. For MSH6, we recommend a somewhat later start at age 30, and that can be every 1 to 3 years for colon screening. And for PMS2, similar recommendations, although I think there is a chance in the coming years we may actually expand the screening interval even more, again, because the risks are somewhat lower. We still have a ways to go in terms of screening for the other cancers in Lynch syndrome. I'll say that, for instance, endometrial cancer, which is the second most common cancer in this disease, we still struggle with what is the best way to screen women for a risk of endometrial cancer. Our guidelines in the past were always somewhat draconian, that once women sort of finish childbearing, they should immediately have a total abdominal hysterectomy and oophorectomy. And I'll say that with greater input from the gynecologic and gyne-onc community, we have somewhat softened those recommendations, especially for the endometrial cancer and also the age at oophorectomy, because we recognize that there were compensatory risks of taking the ovaries out too early in some women, risks of bone loss and cardiovascular disease. So those are the most common for other tumors in Lynch syndrome, for instance, gastric cancer and pancreas cancer. The guidelines are still really evolving, and different groups have put out guidance for clinicians, and I'll say NCCN, which I participate in and help write those guidelines, has very good recommendations for docs. But I'll say that it is, again, back to the idea that it's a moving target. And as we learn more, hopefully we'll have better recommendations in the future.
I completely agree as far as a moving target is concerned. And we often look at the disconnect between the recommendations and then what's implemented or followed in the real world setting. So I have a question in that context. And my question is, when you identify these individuals with Lynch syndrome, perhaps let's talk about academic settings, and then we can try to delve into how this might work in the real world community oncology settings where the real world population actually exists. 60-70% of individuals get treated in the community. So when you talk about an academic center, what is the flow of the individual? Does the individual stay within the geneticist when they're diagnosed? Does the individual go to the primary care and the geneticist makes the recommendation, the primary care follows the recommendation? How does it work for you? And what are some of the models that you've seen work best, perhaps at different academic centers?
I think you get at a really great question. And I'll say there is really no one model. And I think models have to be fluid these days because people with Lynch syndrome are really being identified in more and more diverse settings and by diverse means. I'll say at my own center, we're more of a traditional practice. So we do the pre-test and the post-test counseling. Once we have counseled individuals, identified Lynch syndrome, we will usually make referrals if folks don't have a gastroenterologist that they have interacted with before. We keep them in our own group and follow them. But their Lynch syndrome home really sits both in a continuity clinic that I run for patients to come back and circle around every 1 to 2 years just to review guidelines and review their screening results. However, I do really make an effort to, first of all, keep primary care docs involved because I think some of the things we recommend, it is critical that the primary care doc is aware so that patients are keeping up with some of the recommendations. For instance, we often recommend skin screening to make sure that folks have had at least one good skin exam somewhere in the 40s. And I think the primary care doc can be very helpful in making sure that happens. It is somewhat different, I think, in the community where many more patients with Lynch syndrome are being identified these days. I suspect that much more of the burden of making sure Lynch syndrome patients are well hooked in with a gastroenterologist and with a dermatologist and maybe a urologist probably does fall on that primary care doctor. In my experience, some primary care physicians have really kind of jumped up and taken hold of this and really know their Lynch syndrome well. And I think that's amazing. I do, however, as kind of an expert in this area, I do get a lot of referrals in from the community as well, from docs who just feel that they may not have quite that expertise that they can get at a comprehensive center. So someone may come in to me just for a consult to review what my recommendations would be, hear about research, hear about what's going on in the field. And those folks will often touch base with me again every couple years or so. Often another thing I've started to experience is that I may meet people once or twice early on in their diagnosis, and then they go back to their primary docs, and I may not hear from them again until something more profound happens in the family or into the patient. And, they get their screening colonoscopy and a stage 1 cancer is found. Often then that's the patient who, after 4 or 5 years, will contact me again and say, we haven't talked in a while, but something has happened, and can we reconsult about what would be the best way to do things?
Again, like you said, lots of moving targets, moving aspects to this whole care of these individuals. Do you think, in your experience, nurse navigation, maybe some centers have already implemented that, perhaps you might have that. Do you think nurse navigation could play a certain level of role? You know how in the multidisciplinary care, we have nurse navigators, they coordinate care between radiation oncologists, medical oncologists, thoracic surgeons. So that's something that is being implemented. My second part of that question is telehealth in this case. Maybe it's a little more difficult for somebody to drive 3 hours to come to you for a visit just to check in versus maybe virtually talking to you, getting it, and you or your team getting a sense of where things are at in terms of their screening and their follow-ups.
I think both great questions, and absolutely we use both of those pieces in our model, and I know from colleagues that they do as well. So in terms of navigation, we do have an embedded nurse navigator within our department. She joins and kind of helps facilitate all of our high-risk follow-up clinics. Mine for GI, we have a high-risk prostate clinic. We have several high-risk breast clinics, and those are populated by providers. We have a couple of nurse practitioners in my genetics group and a PA. They are sort of the main provider in those clinics, but they are very much supported by that nurse navigator who, as you well point out, really helps with the coordination of the care. Telehealth as well, I do 100% support, because you're absolutely right. If you look at a map of the United States, you first of all look at where there are good counseling services available. Of course, there's ample counseling in the major metropolitan areas all over the US. But the minute you get outside of those, counseling and then other management expertise is thin. So we do have a model where, particularly for folks who are from central Pennsylvania and sometimes more towards western Pennsylvania, I do have some individuals who've been identified with Lynch syndrome who telehealth in, again, for that follow-up. Sort of side note on telehealth, I think we learned a lot from the pandemic about how to use telehealth more effectively. And thank goodness we've all gotten up to speed in medicine of how to be better telehealth providers. Unfortunately, I feel like with the pandemic kind of waning, there's been a little bit of a regression of the telehealth laws. So now if I want to do telehealth with someone who is from New Jersey, even though New Jersey sits very close to where I practice, it's more complicated. Now, again, I have to sort of get a license, and same thing with New York and same thing with Delaware. I sort of wish we had a little bit of a better and welcoming system in the States where you could have easier ability to practice, especially when states were quite close, using telehealth. But nonetheless, that's for another podcast, I think.
Well, thank you again for some of those interesting aspects to this whole topic. But let's dive into the thing that we are here to talk about, which is aspirin in these individuals. So can you give us some context on why aspirin, what's the biology there, and what's the data there, and then talk about why you did what you did?
So we've known for many years that aspirin has preventive properties in terms of preventing colorectal cancer. Many observational studies and some interventional studies have shown us that aspirin has benefits for reducing the risk of colon cancer in an average risk population. There was even an interventional trial a number of years ago that looked at individuals who made polyps And this looked at particularly adenomas, which we know are the precancerous polyps, and adenoma prevention using aspirin. And that study clearly showed that aspirin had benefits for lowering risk of recurrent polyps and adenomas. Particularly, even a lower dose of aspirin, 81 milligrams, was effective in that setting. Aspirin's also been studied in other hereditary risk syndromes, the most visible one being FAP, where data have shown that aspirin does help reduce polyp count. And in FAP, although it's certainly not a perfect chemoprevention for that disease. So in that background of knowing that aspirin has many benefits for colorectal cancer prevention, a study was initiated in the UK a number of years ago called the CAP2 study, with its lead investigator being John Byrne. And in this study, it was a 2-arm factorial study that it was not just aspirin, but they were also looking at resistant starch, which there was a lot of excitement about resistant starch back then. But in this study, they looked at using aspirin as a way of lowering risk of colorectal cancer in patients with Lynch syndrome. That study, which was initially reported in the New England Journal, the initial outcomes did not actually show benefits in its first analyses of adenoma risk and colon cancer risk. But what they found over time was that there was a delayed effect. And in a follow-up paper looking at 10 plus years of follow-up, they showed a substantial reduction in risk of colon cancer, about 40% risk reduction, which was really striking and exciting in the field to see such a large benefit from aspirin. Now, one caveat was in the analyses they performed, it was those individuals who were able to stick to the aspirin dose in that study, which was 600 milligrams a day. I always say to folks that, back in the day, that was not a lot of aspirin, although I think these days we're much more skeptical about taking larger doses of any drug. So 600 milligrams, is roughly about 2 adult aspirin in the US. So those folks who were able to stick to that dose for at least 2 years were the ones who gained benefit from being on aspirin. And what was interesting is that benefit endured for really 10 years after those 2 years of being able to take aspirin. So this was striking and really changed our thinking about whether there may be chemoprevention options for folks with Lynch syndrome. However, and I think what formed the background of our study here was that there was a somewhat equivocal endorsement of aspirin by the major guidelines committees, mainly because, as we all know in oncology, we love one first big study, but we always really love secondary studies that solidify the finding of the first study. And so because this was such a niche group and no one else out there was doing big aspirin studies, when this result came out in 2011, we've sort of been waiting for many years for some follow-up data. And the NCCN guidelines have always been a little bit equivocal that people could consider using aspirin to lower risk in their patients with Lynch syndrome. But without that kind of strong, everyone should do this. And so this has kind of formed the background of why we formed the study that we did.
Interesting. And then you had a bunch of observations, one of the most important ones being that use of aspirin was pretty low. Could you dive into that and help us understand what were some of the factors surrounding those low implementation aspects?
Of course. So what we were interested in then, again, in that background was, here's a high-risk population. Docs are getting somewhat maybe ambiguous information from the guidelines, but what actually is going on out there in practice? How many patients are actually using aspirin? What doses are they using? And what are some of the factors that drive it? So we performed a survey that actually occurred in 2 parts. One started at Fox Chase in our population here, and then we expanded it online to a convenience sample. Overall, we had 296 respondents. And what we found actually was the uptake of aspirin was only about roughly 35% or so among patients who were eligible to take aspirin. And when you actually drilled down to those people actually taking aspirin because they wanted to prevent Lynch syndrome, it was even lower. It was in the range of 25 to 30%. This somewhat surprised us. And then when we looked at the doses that people were using, of course, thinking back to that 600 milligram dose that was tested in the study, we found actually that more than half of folks were taking low dose aspirin, like an 81 milligram, and only about 8% of our study participants were using that 600 milligram range. So again, I would say this somewhat surprised us because we thought it might be higher than this. I'll say as a somewhat caveat to this, though, is that back to my comment about we always like another study that confirms our findings. And at a meeting earlier this year, there was a study performed in a New Zealand population, a medical oncologist named Rafeh Naqash, and she actually found almost the same identical results that we did in the New Zealand population. Very, very similar uptake rates of aspirin in the New Zealand population with Lynch syndrome. So kind of confirming that something we've stumbled upon appears to be true. But how do we understand why some folks use aspirin and why others don't in this condition?
You had a very robust questionnaire from what I saw in the paper. And some of the questions that I had around that was, did you or were you able to account for demographic education level of the individuals? Were you also able to assess whether these individuals felt that they have been counseled appropriately when they met with either a primary care physician or any provider on the genetic side, physician or non-physician? So how did you get an assessment of whether it was, an apples to apples comparison, or were there a lot of confounders?
Very good question. And of course, in the setting, unfortunately, we weren't interviewing people, which we could have gotten much richer data in some ways. And there were other things we were looking at in this survey as well. So our aspirin questions, we had a number of them, but perhaps in retrospect, it would have been nice to even have more. But so we did have some common covariates: age, sex, ancestry, marital status, which gene was affected, whether they had a history of cancer. We did not have education, unfortunately. And I think your question is a great one, but we did not actually ask folks about whether they had been counseled by their provider or their genetic counselor or someone else about whether they should use aspirin or not. We simply wanted to see whether folks were using it. We did ask them again whether they were using it because they wanted to lower their risk of a Lynch syndrome cancer, or whether they were using it for another reason or a combination of both. So yes, in retrospect, we actually do have another study plan to kind of drill deeper into these questions of, is it more of a hesitancy question? Is it more of a question of just not as much awareness? Are there other reasons? I think there's a lot to answer. And I think answering these questions is really important because we both want to make sure we're talking about interventions that we think can help people, but we need to understand also some of the barriers they may face. And if people do have barriers to some forms of chemoprevention, or I think about some of the vaccine research that's going on right now. If the kinds of things that we're working on to develop are actually not going to be palatable to the patient, the population, then I think we kind of need to step back and say, we need to maybe understand what people want so that we can have a good meeting of what's going to work and what's going to fit the needs and lifestyles of our patients, because these are things that they might have to do for many, many years, right? And starting maybe even in their 20s or 30s. So it makes a difference.
From what you learned in the study, are you thinking of any subsequent interventional approaches, whether they involve, a simple phone call to the patient regularly, or perhaps, even though I'm not a big fan of EMR prompts, like an EMR prompt of some sort where they're instructing the provider, whoever is seeing the patient, physician or the APP or the geneticist, hey, did you counsel the patient? And it's sort of a metric, how in the oncology side, they say your metric is you should stage all patients and you should talk about toxicities from a reimbursement standpoint and also from a quality improvement metric standpoint. Is that something you're thinking of?
100%. So when we looked at the barriers, many of the things that were the strongest predictors of who used aspirin versus who didn't were really patients' perceptions of aspirin, of whether aspirin would cause side effects or whether aspirin would be burdensome to take on a daily basis. Also, just how much benefit they thought would come from taking aspirin. So I think there's number one, I think an intervention, and our next delve into this as an interventional study would be both education about the delta prevention benefit that you get from aspirin, the safety profile of aspirin, which is really quite excellent. And also, I think the data that are so important that in this study by Burnett et al., it was actually only 2 years of intervention that then paid off for 10 years down the line, right? So I think that's important. The other thing that we actually learned as an aside in this study was actually the kind of intervention that patients wanted the most was actually not a drug and was not a vaccine and was not another kind of special scope to stick, somewhere. What they actually were most interested in were interventions related to diet. People really see diet as being an important part of health, or I should say diet and nutrition. And so I think a subsequent study would perhaps wed both a nutritional intervention of some kind with a chemoprevention in some sort of time limited fashion so that folks felt like they were both focusing on something that was more important to them, but also something that was related to the study that we wanted to look at. So that's kind of my idea of where we're going to go in the future with this.
Excellent. Sounds like the next big R1 for your group.
Let's hope so.
Well, I hope the listeners enjoyed talking about the science and learning about aspirin Lynch syndrome. The last couple of minutes are about you as an individual, as an investigator. Can you tell us what your journey has been like, how you ended up doing what you're doing, and perhaps some advice for early career junior investigators on what this whole space looks like and how you paced yourself and how they can learn from it?
I really got interested in oncology during my residency training. I really found that I really liked oncologists. I found them to be a bit more of a science focused group. They liked research, but you're in oncology because you understand the fears and the challenges of cancer. And so it's both a combination of that love of science, but also that real human touch of taking care of people. The thing I always tell my fellows as well is the other thing I love about oncology is if you tell people they don't have cancer, they don't want to come back to you. And now, of course, that's modified in the prevention setting. But I really like that when people come to me in my GI oncology clinic, it's because they have a diagnosis. And if I say you actually don't have cancer, they go off to their life. And so you're really spending your time on real subjects. The person who really got me most interested in Lynch syndrome and this kind of prevention research was a mentor from University of Chicago, Fumi Olapade, who really has been an enormous mentor for many, many people in the field. Actually, 3 people in my fellowship class all went on to careers related to genetics and genomics. So she's been highly influential and continues to mentor me even in my mid-career. I think in terms of pearls or what keeps this interesting for me, I think as much as oncology treatment and new drugs and trials is super exciting, I love being able to step away from that into my genetics and prevention population and kind of focus on treating people in a different format, patients who are healthy but are worried about cancer because of a family history or carrying a gene or otherwise. And I feel that that's where I can have also an important impact, but on a different level in educating people and helping them understand how genetics works in a understandable and simple way, but also giving them some tools. And one reason for this study and the reason I study preferences related to prevention is, again, I don't want to just develop something and spend 10, 15 years of my life, developing some intervention that everyone looks at and is like, I don't really want to do that. I want to really understand what it is that is important to the patient so that we can hopefully work together to develop things that can not only have impact, but have impact on a wide scale.
Awesome. You mentioned Dr. Olapade. I crossed paths with her actually at an International Medical Graduate Community of Practice session earlier this year at ASCO, where she talked about her journey as an immigrant, talked about how she started, the kind of impact that she's had. It was obviously evident in the picture that she showed with all her mentees from all over the world. That was very phenomenal. And it's surprising how small of a world we live in, where everybody knows everybody else.
More so than anyone I think I've met in my career, she is really a huge believer in mentorship and spending that extra time with your mentees. And she has been someone who has continued to promote me as an investigator and build me up and get me involved in things. And like I said, I've been in oncology now for quite a few years, but having that person who I think is always thinking about their trainees and people who have learned and grown under them, because what it does is it gives you that fire as well as an investigator to do the same thing for the people that you are a mentor for and train. So I try to be just as good of a mentor to my genetic counselors and the fellows who come through me and my APPs to give them opportunities, to get them excited about research, and when they have these big moments, to do that. So yeah, I know Fumi just has had a huge impact on the field of genetics. I still remember some of our early conversations on the wards when she said to me, "Oh, this is such an interesting case. We don't really have anyone who's studying Lynch syndrome so much right now, and you should really get into this area." And I remember thinking, okay, I want to develop a niche, and here's a niche that's waiting.
Clearly paid off big time, and you're paying it forward with your mentees. So thank you again for joining us. This was an absolute pleasure. Hopefully the listeners learned a lot about the science and also your journey and how you're trying to impact the field. Thank you for listening to JCO Precision Oncology Conversations. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.